This class today, Transitions in Retirement, is part of the open to the public, so we welcome both non-members and members to this class. Okay, next I'd like to introduce our presenter. As I mentioned earlier, Dr. Vercammen-Grandjean, Christopher Vercammen is our presenter today. And he's a general internist seeing patients in his Yorba Linda office with St. Jude Heritage. He is originally from the Bay Area and completed his medical school and residency training at the University of California, San Francisco. He has a particular interest in geriatrics, especially chronic disease management in older adults. He lives in Orange, California, with his wife and 4 children. Let's welcome him today.
Hi, everybody. Thank you for being here on a Saturday. Appreciate it. Thank you for that nice introduction, Russ. I'm going to go ahead and share my screen here with my presentation for today. PowerPoint etiquette being minimum to keep yourself independent, living at home without needing help or having to move to a setting, you know, like what sometimes prompts people to move to like assisted living or higher levels of care. The IADLs are sort of things that you can usually get help with that don't necessarily preclude independent living. So like grocery shopping, doing the laundry, cleaning the house, managing your finances. It's a really important one. One of my mentors at UCSF, Anna Chodos, I think this is the best way to remember. If there's an app on your phone for it, it's probably an IADL, meaning you can order your groceries through a grocery delivery app. You can get takeout through a food delivery app, but for the most part, there aren't apps that are going to help you get in and out of bed or help you get dressed or what have you. Okay. Now, when functional, hopefully it doesn't, but if functional status does start to decline, then we get to this concept of frailty, and frailty is a very sort of wide-ranging term, like much of the stuff we're going to talk about here today, because frailty gets at a decline in these functional markers that predispose older adults to either medical illness, whether it's infections like pneumonia or injuries like hip fractures or compression fractures of the spine, as well as the important outcomes of being able to stay as independent as you wish to be in terms of your home setting and your social activities and whatever that might be. And one key here that we see in research is that functional status and frailty generally are better predictors of longevity and quality of life than specific lab tests or specific, you know, kind of screening tests or whatever it might be. Even though they're somewhat vague and nebulous terms, they hold a lot of predictive power if we're trying to figure out, for instance, is someone going to be able to safely have a surgery they need, or is someone safe to remain at home without additional help, or does someone maybe need to consider moving to a setting where they're going to get more help with their daily living activities. And frailty really it's rooted in biochemistry, physiology, molecular genetics. Even though it may not sound like it, this is a very complex physiologic process, the progression to frailty, but it's not necessarily inevitable. And that's a big part of what we do in primary care, internal medicine, especially for the older adult, is try to prevent the onset and limit the effects of frailty. So how do we measure frailty? This is always an active area of research in geriatric medicine. There's no one way. Interestingly, a few things pop up here. Grip strength is actually a pretty reliable and easy way to measure frailty. So, you know, some places will have these tools where we measure how strong you can grip. And that seems to be a proxy for a lot of things: muscular strength, nutritional status, enabling you to keep your muscle mass, neurologic functioning, being able to take a direction and follow it. There are also some things that you can tell your healthcare provider that give a marker of frailty. Fatigue, unexplained fatigue, a very common thing. I see that every day in my practice. Unintentional weight loss is always something that gets our attention, especially when it comes out to more than 5 to 7% of your body weight. So that would be for like a 150-pound person. Even a 7 to 8 pound weight loss will definitely make certainly me sit up and take notice and do some exploring. Decreased activity, not feeling or not being able to do things you used to be able to do. So let's say you used to be an avid gardener, or you used to play tennis 3 times a week and you're finding you just can't do that anymore. And then just getting around slower. One of the oldest and most helpful tests we have is the time get up and go test. This is what I do in my office because it's easy and I don't need any special equipment. I just have my patients sit in a chair, get up, walk 10 feet and walk back and sit down. And the longer that takes, it actually correlates fairly well with other measures of functional status like ADLs and IADLs. And it's quick and it's easy to do. And most clinicians will do that as part of, sort of these annual wellness visits we do for Medicare with a comprehensive geriatric assessment. So keep these things in mind as we go through talking about all this, because this is going to be really important. It's a picture of Jack LaLanne, who is kind of a pioneer in the growth of physical culture and especially strength training, which is going to come up in some of our sort of our preventive measures, hopefully to ward off frailty as people age. One of the things I want to spend a little bit of time, because this is often something that comes up with my patients, and I think it's a really important sort of causal factor as it relates to frailty, is this idea of sarcopenia. So you've heard of osteopenia, which is sort of the thinning and loss of bone mass. Sarcopenia is its cousin. It's the loss of muscle mass that seems to progress and even accelerate with age. It has a number of causes. Without getting too into the weeds, both men and women produce testosterone, obviously men in higher amounts than women. But testosterone is very important for maintaining what we call a positive nitrogen balance, meaning we're making more protein than we're breaking down. And protein calorie malnutrition is a big problem in older adults that can lead to sarcopenia and frailty. And one way we potentially could ward this off is by promoting not just, walking and swimming and riding a bike are great. Those have their own clear benefits for cardiovascular health, cerebrovascular health, mental health, emotional well-being. But trying to get away from, I think what's been a bias in both popular culture and in healthcare against resistance training. And resistance training and weight-based exercise are really, really important, because that's what stresses your muscles and forces them to stay strong and for your body to want to build more. I've cited, I don't have this is not an academic talk. I'm not going to have a long list of references here, but I have just put these in here to show, to give you a sense that yes, there are data to back up these things that show that engaging in even a moderate, not super intensive, I'm not talking about CrossFit or boot camp here, just a moderate resistance training regimen can certainly be a huge benefit in terms of slowing down the progression of sarcopenia. Another big thing that comes up in the older adult is this issue of decreased energy expenditure for the reasons we talked about. You're not maybe doing as much. You don't have as much metabolically active tissue. You're losing muscle mass. You don't need as many calories, and that's okay. This is not to say that you should be trying to force calories into yourself more than what you otherwise would, especially as we're going to see that in terms of thinking about longevity and health, that may actually not be a great strategy. However, we do want to make sure we're not getting in protein calorie malnutrition, meaning a deficiency of protein in the diet, because that is something that has also been associated with both decreased muscle mass, and by increasing it, we can increase muscle mass and strength, which is going to be really important in maintaining functional status. So to expand on that a little bit, nutrition in terms of physical health, prevention of frailty, in my opinion, it's all there. And what I tell my patients, as you'll see in the second bullet here, let's pick a healthy foundational diet like the so-called DASH diet, which is the diet to stop hypertension, dietary approach to stop hypertension. Which is pretty intuitive. It's eat a lot of fruits, eat a lot of vegetables, limit starchy carbohydrates and sugars. limit really calorie dense foods, especially in particular, unfortunately, takeout and restaurant food, or the Mediterranean diet, which has its own sort of prescriptions in terms of the breakdown of how much fat you take in, the sources of those fats, obviously more nuts and oils, less animal proteins. I'm not advocating for one or the other. Different patients are going to have different needs that are going to benefit from different sort of more prescriptive diet approaches. But in general, what we want to make sure is that whatever you like, whether you're a vegan or whether you're a meat eater, that we are getting you enough protein in your diet, which by the sort of consensus right now in the literature I reviewed, about 1 to 1.5 grams per kilo of body weight. So kilo is, to get kilos from pounds, you divide by 2.2, more or less. So I use the example for a 180-pound man, it would be 70 to 90 grams of protein daily. So if you look at it like in terms of, I picked a couple just representative foods, one egg has about 10 grams of protein. One normal size skinless, boneless chicken breast, depending on how much it weighs, is going to have 30 to 40 grams of protein. So it's not hard to get there, but it does take something of a conscious effort. If you don't like animal protein, or you don't eat it for personal or religious reasons or whatever it might be, your main sources are going to come from legumes like beans, nuts, almonds, peanuts, technically a legume, and then in derivatives of those products. Plant protein is a good source of protein, and there are protein supplements too. A word on that: don't feel bound like you have to buy the brand name like Ensure or whatever it might be. Honestly, the Costco brand of nutritional shakes are great. And if you just can't bring yourself to eat that much solid food in a day, but you want to get a little more protein, those are a decent option. Be mindful if you're lactose intolerant. A lot of them can have lactose in them. And obviously, if you develop any sort of untoward side effects, you should let your doctor or your advanced care practitioner know, because we might be able to help you troubleshoot what's causing that. The only other thing I want to highlight, in terms of nutrition, that's really important in prevention for things like hypertension, high blood pressure, coronary artery disease, etc., is salt intake. This is another thing that I have a lot of conversations with my patients about, because salt is hidden in a lot of the foods we eat, in particular pre-prepared foods. So the stuff you take out or fast food, as well as pre-prepared foods in the store. So frozen meals, the stuff that the store kitchen, whether it's like Stater Brothers or Whole Foods, the stuff they prepare, it has a lot of salt in it because that's what kind of keeps it fresh for as long as it needs to on the shelf, and it also makes it taste good. That tends to be where people get hung up on salt, and that can, like I said, can affect blood pressure and risk for having heart attacks and strokes. So be mindful of that. If you prepare most of your food at home, you're probably okay. It's really hard to salt your food to the point that you're oversalting it. We recommend no more than like 2 grams a day or 2,000 milligrams. So for fun, you can take a look at your nutritional labels. If you pick up a can of like Campbell's or Progressive soup, you're going to see that a whole can usually has, if not close to, sometimes more than the daily allotment of salt. So that's kind of what I get at with pre-prepared foods. They're convenient, and then it doesn't mean you have to avoid them completely, but just be mindful that there's a lot of salt in them. What about nutrition and longevity? So we talked about, how to prevent things. That follows from that, well, if I'm preventing or delaying the onset of heart attacks or strokes or dementia, less clear that nutrition has a significant impact on it. It may have some, but if I'm preventing all these things, I should live longer, right? Potentially, yes, but this has really become in the last at least 5 to 10 years a big area of research, particularly in the area of longevity research. Longevity is an interesting concept in geriatrics and in the care of the older adult, because sometimes it can almost feel like we're running at loggerheads against each other, because we spend a lot of times in geriatrics talking about functional status, defining your goals for your life, for that phase of your life, and then honestly talking a lot about end of life too, whereas longevity sometimes can feel more like talking about how can we delay the inevitable of ill health and then eventually death. But there's a lot of care. There's a lot of areas of shared interest, and honestly, we're talking about the same things because we're talking about the best possible quality of life for the longest possible time. The only thing overall, the studies, regardless of quality, that seems to hold fast is that the fewer calories you eat in a day, that seems to promote greater longevity. This comes from, sort of lower quality scientific studies, which is observing, certain like religious groups who fast as part of their religious practice do tend to live longer. And then also more observational studies where people actually track their calories, and we see that lower calorie intake seems to correlate with more longevity. Why is this? It's been shown on a cellular level to reduce the amount of degradation and sort of breakdown of cell components, which means less cell turnover, which in theory means less chance for developing things like cancer, atherosclerosis, and so on and so forth. Now, a lot of these data are also coming out of things like animal studies, so obviously take that with a grain of salt. But I think we can pretty easily fit this into what we said before, in the sense that we got to use the calories that you take in wisely. And that means looking at how nutrition breaks down and how we can use the 12 to 1500 calories. And this all depends on how big you are, how active you are. Certainly, if you're still lifting weights and playing sports, and that's great, and I love it, then you're going to need more. If you're more sedentary, you may need less than 1200 calories. Rule of thumb, 800 is kind of the lowest that most people would feel safe going, and that's quite low. I usually have my patients kind of aim for 1000 to 1200, at least to start, though I certainly have patients who are just smaller and not very active who don't need as many calories. But looking down at the bottom of the slide here, we know protein, these are all estimates, but it has about 4 calories of energy. That's what a calorie is, just a unit of energy per gram. So if you eat 70 grams of protein in a day, that's only 280 calories. So that means you have, if you're eating, let's say 1280 a day to make the numbers nice and round, that leaves you 1000 calories to use for your fats and your carbohydrates. Fat is energy dense. So if you ate 30 grams of fat, it's about the same amount of calories as 70 grams of protein. But there tends to be less fat in general in a lot of the healthy foods that we eat anyway. So this kind of shows you, if you just make the foundation of your diet fruits and vegetables, add in enough protein, then the rest you can kind of use to get your fat and anything that tastes good too. I'm not a big fan of saying you can never eat this or that, even if you have something like diabetes or hypertension. We're not here to deprive, we're just here to be mindful of how to keep these things balanced.
Bolin has a question.
Yes, I just want to confirm, you said that regarding, let's see, it's better to cut down your daily intake than it is to periodically fast in your diet. Is that correct?
It's a really good question, and I would say the answer to that is still somewhat open. When we talk about intermittent fasting, which I didn't get into as much, but this is a good opportunity to, it's interesting. The New England Journal of Medicine, which, I think for any practicing internist is really kind of our go-to for what people are talking about in the field, published, it's been a couple months now, a whole clinical review of intermittent fasting, starting from the basic science, what's happening, on the molecular level, all the way up to how to do it. And the data, again, they're very incomplete. We don't know yet. But you can do it one of two ways. You can either cut your daily intake and just, like we said, 12 to 1500 a day, or you can pick a day or two where you're going to do a much reduced intake. So you could pick a day of the week where you don't go over 500 calories. Obviously, you're going to be hungry. But that does potentially, it seems to provide the same amount of benefit as if you fast every day or cut your calories every day. It's a great thing to bring up because, a lot of patients have questions about this, or they maybe been trying to change their body composition, lose weight, gain muscle, whatever it is. And what I tell them is you got to find the approach that works best for you. If you are going to go nuts every day, having to limit yourself to these calories, go ahead and pick a couple days where you're going to really hunker down and stay under, 800 or 1000 or whatever. And then that gives you a little bit of leeway on the other days. Now, obviously, if you go crazy and eat 3000 calories, you're not going to lose weight, and, you may gain muscle, but you're going to gain fat mass as well. But at this point, I think that's an open question. I think you have to find the approach that works best for you, that you can tolerate the best, because some people are going to be better than others at limiting daily intake. Now we're going to kind of transition into getting into the stuff that I do in my office, which is really going to be talking about medications. every physician, every nurse practitioner, every PA you see is going to have their own personal approach and their own personal kind of set points about when to start things. Now, obviously, in general, if we're all following the same evidence and guidelines, those are all going to be pretty close together. And you're going to have a range. You're going to have some providers who are a lot more aggressive about starting cholesterol medicines or blood pressure medicines. And you're going to have some who, and I probably fall more in this category, who are really going to try to get the quote unquote lifestyle or non-pharmacologic approach down first. And then if we're just not getting there for whatever reason, then we use the medicines as an adjunct to really help you hit your target. And the reason for this is what I put up here first, and this is another big topic in geriatrics, is this concept of polypharmacy. Polypharmacy, I can't point to like a dictionary definition. It's highly dependent on the types of medicines you're on, how they interact, what your other health conditions might be. But in general, polypharmacy is just what it sounds like. Poly meaning many, pharmacy, in these days referring to prescribed medications or non-prescribed medications, things you get over the counter, but having too many of them. And this is a very common concern I see, especially when I have a new patient coming in, and oftentimes one of the first things they ask me is, how can I get off all these medicines? And the answer is oftentimes we can shave down some, though, well, let me put it this way. And this bleeds into what sort of is going to end this talk, which is talking about goals of care and advanced care planning. There are no medications, by and large, that you have to take every day, but there are trade-offs. So if you don't take your blood pressure medicine and your blood pressure runs high, we know you're putting yourself at increased risk of stroke or heart attack. So it's really important, rather than like, oh, let's just try to shrink the number of medications. What I really like to talk about is why were you put on these medications? Is it really the right diagnosis? And how do you feel when you take them? Oftentimes when people stop their medications, it's because they don't make them feel good. They get dizzy, they get tired, they get fatigued, they get a dry mouth. It affects their libido. It makes their stomach upset. Those are much more important than just taking a look at the actual numbers of medications. So that's my starting point. I'm just owning my bias. My set point is to really try to keep the medications down to the bare minimum that we need to provide some benefit. Pardon me. But it's going to be highly dependent on patient. The example I use is I have patients come in, they have a long med list, but 4 of them are eye drops because they have glaucoma and they have, maybe uveitis or some other thing. They may be annoying to take, but they're kind of important for vision. Vision's very important. And they're not really pills that you're swallowing that are exerting a systemic effect. Same for like creams you might use for pain or arthritis, or topical medications, inhaled medications. There's obviously some systemic absorption, but not to the same degree of a pill that you take and swallow or something you inject like insulin. So not all medicines are created equal. And then even amongst medicines, as we're going to see, there are various degrees of side effects and interactions. And the problem is, in general, as we add more medicines, as you can imagine, you don't have to be a statistician or a mathematician, we're increasing the risk of an interaction just because there's more things to interact. That being said, we're not here to be the term that we throw around sometimes as therapeutic nihilists. We're not here to say nothing works, nothing matters. You get old, it is what it is. We can't help you in any way. That's not true. And I think one of the real landmark trials that I've chosen to highlight here, and you come to the talk on Thursday, we're going to dig into this a lot more, is, sorry about that. We're going to talk about a lot more is the SPRINT trial. The SPRINT trial was really a landmark study because it was a randomized controlled trial done back in 2015 that went out and actively enrolled adults over the age of 75. The other 99.9% of the time in drug-sponsored trials, it's the opposite. They try to keep enrollment to a very tight age range, usually somewhere between 40 and 65, because that's what's going to give them the best chance to show a benefit without a lot of side effects. So this was a study that was really important because it took the population for whom we had no specific data and studied whether tight blood pressure control, meaning shooting for 120 over 80, like we do in younger patients, whether that was better than what we did for many years in the care of older adults, which was so-called permissive hypertension, where we let it go, we'd let the top number go up to 150. I'm sure a lot of you check your blood pressure at the doctor or at home. And that's really been a sea change, because it turned out that even just trying for tight control did seem to confer a benefit in mortality without causing too many other side effects like falls or dizziness or things like that. Like I said, we'll get more into that on Thursday, but it just goes to show that certainly there is a role for medications in the prevention of disease, because what was contributing to mortality in the SPRINT trial, you can probably infer, were things like heart attacks, strokes, heart failure, things that relate to blood pressure control. But on the flip side of that, we've known for years now that while still very open to debate, and I'm sure some of my cardiology mentors at UCSF would kick me for saying this, is that statins like Lipitor, rosuvastatin, or Lipitor, atorvastatin, or Crestor, rosuvastatin, there is some signal in the observational data that they seem to be associated, though not necessarily causing things like cognitive decline, dementia, diabetes, fatigue, a whole bunch of a litany of things. Now, again, these are just things that deserve more attention and exploration. Anecdotally, especially since I've moved my practice down here from San Francisco, a lot of my patients seem to experience side effects from statins. So we have to figure out a way to work around that, which is why I start with nutrition and not medications. However, statins certainly do help, even in older adults. And we learn this because there's been a big push in geriatrics, which I think is largely a good thing, to so-called deprescribe, meaning reduce the number of medications that a patient is on at any given time. However, what we saw, and this is from a study in the last couple of years, I think came out in the Journal of American College of Cardiology, that there is an increased risk of heart attack and fatal heart attack immediately after stopping a statin. So they're still doing something even in older adults. Decisions about stopping are going to pertain, and we're going to talk about this a lot in the next section on screening, are really going to be based on the individual setting in terms of your overall health, your goals, your wishes, and life expectancy and longevity. Okay. Now, getting into specific medicines we do try to avoid. We do our best. This is not prescriptive. Certainly certain health plans, I know Kaiser in the past has tried to be very prescriptive about this and said, if you're over the age of 65, you can't get Ativan or you can't get Valium. It's not that cut and dry. However, we know there are certain medicines we really should try to limit the frequency and dose of. And it comes from this thing called the Beers criteria. Beers criteria, the Beers list, so to speak, is this sort of consensus-driven approach. It's based on evidence, but it's just a bunch of experts getting together and sort of talking about things and putting out a list. First one came out in 1991, so what now constitutes a long time ago, almost 30 years. It gets updated every few years. Most recent was last year. It's a long list. I'm not going to go through them, but I am going to kind of highlight some of the things I see in my practice a lot, that I spend a lot of time working with my patients on. So the big one, the big bugaboo, is mixing narcotic/opioid pain medications. So like Norco, Percocet, OxyContin, MS-Contin, Tramadol, etc., and benzodiazepines, which are Ativan, Valium, Xanax, Halcyon. There's a whole bunch, including even things like the Z drugs like Ambien, Zolpidem, Lunesta, Zopiclone. I lump these in too because they work on the same receptor in the brain. So really, we try to avoid mixing these. Are we always successful? No. But we know this increases not just the risk of falls and things like that. This actually confers an earlier mortality risk. Meaning you would die sooner than you might otherwise would have if you weren't doing this. So it's really worth thinking about, talking about. Sometimes if a person has some other competing health issues, their longevity isn't going to be 5-10 years as best we can guess. It may be worth the trade-off that just, look, I feel better when I'm on both these medicines, and I understand that it may shorten my life a bit, but my quality of life goes down so much if I'm not taking these. I just can't imagine that. That's at least a starting point to have the conversation. It may not be the answer, but it's a starting point. The next class of medications that I like to highlight are these so-called anticholinergic meds. Anticholinergic meds, there's a neurotransmitter in your body called acetylcholine, and it's super important for gut function, for bladder function, for brain function, for muscle function, all the above. So you can imagine that medicines that interfere with its function can really cause a lot of problems. Bad actors in this that you can get over the counter are all the PM drugs or sleep drugs. So whether it's Unisom, Advil PM, Tylenol PM, what makes them sleepy is Benadryl and its cousins, doxylamine, diphenhydramine, chlorpheniramine. These are all antihistamines. They block histamine, so we use them as like allergy meds, and they have a byproduct of making people really sleepy. Unfortunately, they also cause a lot of anticholinergic side effects, which can run the gamut to confusion or delirium, not being able to get your urine out, constipation, heart rhythm abnormalities, dry mouth, dry eyes, dry other mucous membranes. So, for women, vaginal dryness, common problem in older age, these can make these worse. So that's another one we try to limit. A lot of prescription drugs are anticholinergic. I can't even run through them all right now, but it's something to bring up to your doctor or your provider when you see them. If you're having those symptoms and saying, are any of my medicines potentially anticholinergic? Last one, and this comes up a lot when we're talking about using antibiotics. There's a lot of reasons we try to be really mindful about how we prescribe antibiotics. In my patients who are older, I always throw in a caution that virtually all the antibiotics we use, by virtue of how they work, can cross the blood-brain barrier, get into the brain, and cause confusion or delirium. Delirium we're going to talk about a little more, talking about dementia and cognitive decline, but you can think of it generally is an acute onset of confusion that can run from confusion to not being able to walk, not being able to talk, not being able to do stuff you usually can do, like cook or whatever it might be. So it's another thing to think about if your doctor's prescribing or your provider's prescribing an antibiotic, to be thoughtful about, can this affect my cognitive function as well? Let's talk about screening. So now we're moving away from sort of, we talked about nutrition, we talked about exercise, we talked about medications, to ward off sort of general things like sarcopenia or frailty, as well as specific things, coronary disease, hypertension, cerebrovascular disease, which are going to be the big ones we talk about for any population, especially older adults. Now we're going to get into screening for things that we're going to try to prevent, or at least catch at an early enough stage where we can exert a cure. And that's, like I said, what screening means. This is hard because now we're not taking something that we already know about and treating it. We're trying to predict, we're trying to see the future, and we're trying to use tests to make our approach better in terms of seeing the future. This puts us at risk of making other types of mistakes than just what we might do in terms of giving medicines or what have you, that relates kind of the statistical limitations on screening and prediction. I'm sure some of you have backgrounds in quantitative, you have quantitative backgrounds, whether engineering, computer science, whatever it might be. I'm going to give a quick overview of these things because they become very, very important when we talk about deciding when to stop, if to stop, or how to modify screening schedules to fit best with you. So I just put here, colonoscopies. I mean, this is one I think everyone, as they sort of transition to being over age 50 for most people, is when we start doing colorectal cancer screening, which we'll talk about more in detail in a few slides. But what the gastroenterologist is actually doing while you're kind of out in la-la land is they're moving their scope through the colon, and they're just kind of looking and hunting for polyps, but also parts that aren't polypoid, meaning they aren't raised, but they're just kind of funny. And the gastroenterologist is looking for those because they're going to want to, or he or she is going to want to biopsy and find what could be either early cancer or sort of pre-cancer, meaning there's cellular changes on the way to cancer, but it's not full-blown cancer yet, which can then be cured either by the gastroenterologist just cutting it out with the colonoscope, or, having to have surgery or something like that. This is important because, one, we can cure cancer, which is always powerful, but two, we can do it in a way that's much less taxing both on your time, your effort, your energy, your spiritual reserve, your emotional reserve, by doing a fairly low-key procedure as opposed to a large surgical resection, and then adding in things like chemotherapy and external beam radiation, all the other things we can do that are a lot harder to go through. So when we do that, that's called primary prevention. We're trying to catch something before it happens. Secondary prevention is a whole different beast, And I think it kind of deserves its own talk specific to what we're trying to prevent. But in general, this is like if you had a heart attack, let's say you had a stent placed when you were 55. Now you're in the realm of secondary prevention for cardiac disease. Now, rather than trying to prevent your first heart attack, I don't want you to have another one. So we're going to make sure that lifestyle, diet, exercise, we're going to have to be a lot tighter with it, potentially in someone who hasn't had a heart attack. We just want to prevent a second event. And that in the cancer world, it usually means something more like surveillance. So, the example I use, you had lung cancer, the surgeon took out that part of your lung, you're cured. But cancer being a microscopic disease, we want to make sure it doesn't pop up anywhere else in the chest or in the body. So you're going to get kind of regular checkups and imaging and things like that. That's more in the realm of surveillance or secondary prevention. Just another funny cartoon. So before we jump into specific screening, I am going to run through some of these problems, the statistical problems that get in the way of screening, and why. And hopefully this will answer some questions you all may have about, like, why don't we do this, or why don't we do that, or why don't we just do CT scans every 3 months? What would the downside of that be? And we'll try to get into why that might not be a great idea. This erudite gentleman, this is Thomas Bayes. He's a Scottish statistician, 19th century. And again, some of you probably know more about Bayes and Bayes' theorem than I do, but I think it's worth kind of spending a few seconds on it. Bayes' theorem moved us out of the realm of sort of old school classical probability, which was all about the so-called frequentist, meaning the probability is the probability no matter what. You can never get away from the underlying probability. So when you're born, you have some probability of colon cancer. Nothing we do is going to change that. No amount of screening, no amount of treatment, no amount of exercise can change that. It is what it is. Bayes gave us a tool to be able to say, okay, maybe we can use some of the information along your life. Were you a smoker? Were you did you follow a healthy diet? Are you overweight? Do you have a family history of colon cancer? Do you have a certain genetic mutation that puts you at risk of getting colon cancer? Using those data to inform and alter what we call our prior probability. This is very important in screening because the screening test is kind of what we're using to lower or raise the probability of disease. And that's what we're going to need to use to make a decision about whether it's worth doing something more invasive like a surgery, a biopsy, a medical treatment, further testing, all those kinds of things. Okay. So theoretically, just keep that idea in mind because that forms the rationale for why we screen. First thing, for any test we do, it has attached to it a couple things. This has been in the news a lot with the coronavirus testing, so I'm sure a lot of you have been exposed to it. Sensitivity and specificity. Sensitivity is a probability, that's all it is. And what it means is that if I take 100 people who have a disease, say coronavirus, and I do a test, the number who actually turn up positive, that'll be the sensitivity. So if I have 100 people who have coronavirus and I do a test and only 70 turn up positive, that means the test is 70% sensitive, which means 30 of those people, I will wrongly tell them you don't have coronavirus and they do. It's called a false negative. So the sort of evil cousin of sensitivity is the false negative rate. Obviously in screening, that's really, really important because the false negative rate is what we don't want. We don't want to miss cancer. You put you through all the rigmarole of doing a colonoscopy, doing the prep, all that. We don't want to miss, right? So screening tests by very definition for screening are going to have high sensitivity. The problem with that is there's no free lunches in medicine and statistics. As you increase the sensitivity of your test, by and large, you're going to lower the specificity. Specificity is the opposite. If I take 100 people who don't have coronavirus, let's say I'm, depending on your religious orientation, I'm God, I'm some omniscient deity. I know that these 100 people do not have coronavirus, and I test them, and 20 of them test positive. By definition, those are false positives. They don't have the disease. 80% of the time I got it right, but 20% of the time I got it wrong. That obviously has ramifications too. That's going to be your false positive rate. That is important when we talk about screening as well, because it may put you at risk of getting further procedures or tests, not to mention the emotional and psychic cost of worrying about something for a time while you're waiting to get an answer, right? So Those are the two starting points, specificity and sensitivity. An example for specificity, some of you, instead of doing colonoscopies, may opt to or have opted to do the fecal immunochemical tests, the ones where you get the card, you put a sample on it, you mail it in, we get a result. That is a very sensitive test. It will find the tiniest little bit of blood. Its specificity is very poor. And that's why, so I always tell my patients, if this comes back positive, try not to worry, because it still is overwhelmingly unlikely to mean you have colon cancer. It just means we have to do a colonoscopy. But still, some patients, obviously, I probably would have a hard time with that too, because I'm like, oh, maybe I do have colon cancer. So that's what to keep in mind there. Now, the inherent problem in this is I sort of preface this by saying, in order to make sense of these numbers, you kind of have to be that omniscient deity who already knows what people have. But we don't know that in medicine, right? I don't know if when you walk in you have colon cancer or not. So the sort of real world numbers that depend on these things are what we call positive and negative predictive values. So this is where Bayes' theorem is important. It's flipping the script. Rather than the omniscient deity having to know the disease positive or negative in people, now all we know are the test results. So this is, if I do that fecal occult test on you and it comes back positive predictive value, what that's telling me is how sure am I that this means you have colon cancer? It turns out in some populations less than 5%, which means there's an over 95% chance you don't have colon cancer. The problem with these numbers and what makes them hard is that they vary depending on how common or rare the disease is. So for rare diseases, it's really hard to screen for them because it lowers the positive and negative predictive values. So we have way less confidence in the outcome of a test. So if we're trying to screen for like a rare cancer and autoimmune disease, we already know that if we get a positive result, it's much more likely to be a false positive than a true positive, just because it's rare, okay? But screening works pretty well for common things: colon cancer, prostate cancer, lung cancer in certain populations, breast cancer in certain populations, obviously. And then it also means that we can screen more aggressively or potentially more frequently in people who have a high risk. So if you have a strong family history, we're going to do colonoscopies earlier and a lot more frequently than we will if you don't have any family history, right? Same for breast cancer. And then experimentally, we would love to get good screening tests for things like ovarian cancer, endometrial cancer. We have a great one for cervical cancer and pap smears. And then cancers people worry about a lot, things like pancreatic cancer, esophageal cancer, stomach cancer, et cetera, et cetera. We don't have good screening tests for everything because of these issues, because of how hard it is to develop a good screening test that will cover our bases and make sure that it's actually worth doing to people. Okay. This is a quick slide. The receiver operator characteristic. This is sort of putting what I said about the trade-offs and no free lunch into play. So if you look at true positivity, so this would be like 100% sensitive, 0% sensitive. And the false positive rate, you'll note that if you just follow this black line here, this would be not a very good screening test because it turns out there's a linear relationship between true positives and false positives. So it gets to the point where it's a coin flip out here. For every true positive, we're going to get a false positive. That's a crummy test. Even if we move it down, because it's linear, we shrink our specificity and sensitivity, we never gain an advantage. The red line, this is a little better. This might be like a PSA, prostate screening kind of line. We can sort of pick a spot where we balance these two a little bit better, but it's still not great. Blue is really what we want. We want something looking more like blue, because you can see at blue at a 70% sensitivity, we're only getting about 20 to 30% false positive. Obviously, the numbers don't balance completely because this is not drawn to scale, but you can see kind of that's the balance we're looking for, right? For an individual test. So the more kind of logarithmic the curve gets here, the faster it goes up at the start and then flattens out, the better, and which obviously means you get a bigger area here. If you colored in this area, the area under the curve, which you may see quoted in like news articles or things like that, as it gets bigger, then we like the test better, okay? But this is a visual depiction of what I was kind of talking about before with screening tests. Okay, so enough of that. Sorry, I think it's important to have those things in your mind when we talk about screening. Colorectal cancer screening. Since men and women, by and large, are born with colons, colon cancer is the most common cancer. So this is one we're going to screen everyone for. We balance the risks. Obviously, there are risks associated with colonoscopy, but in the hands of an experienced operator, which we live in Orange County, whether you go to UCI or Jude or Kaiser or Hoag or whatever, you're getting an experienced operator. We're not fortunately, we don't live in a resource limited setting where you might not have someone who does as many of these doing it to you. So it's safe. And what's nice about colorectal cancer, I tell my patients, it's a one-stop shop. You get the screening, you may even get treatment. So if they cut out a precancerous lesion, you saved yourself a surgery down the road potentially. But it's not the only way to go. And certainly my take as an internist and as someone who's interested in geriatric medicine, the best test is the one the patient actually is going to do. So I have some patients who just flat out have so much anxiety about the test, they will even get to the endoscopy center, take one step inside, turn around and leave. They just can't do it. That does nobody any good. So I'd much rather pick a test you're actually going to do. And then if it turns up positives, we can talk about what to do next. But at least say we keep getting negatives on the FIT test, the fecal occult blood tests, or the card. It turns out if you do that every year and you sort of multiply out the probability of missing something, fortunately, it kind of turns out that it works about as well as colonoscopy doing one every 10 years. Just means you have to do something more frequently, like every 1 year, or if you've seen the Cologuard, basically the same flavor of test, except you do it every 3 years. So there's lots of different options here. And we try not to let perfect be the enemy of the good. Let's do something that's helpful and get you to where you need to be. For average risk patients, which I'm just going to leave it at that. You don't have any crazy family history or known genetic mutations, or you didn't have 20 like bad looking polyps on your last colonoscopy, but just for the average person getting colonoscopies, every 10 years, if you're totally clean, if there's a few polyps, it may go down to every 5 to every 3. We're moving more towards closer intervals based on more recent data. Unfortunately, the incidence of colorectal cancer has gone up, particularly in younger people. But in general, now I've seen more, my gastroenterology colleague is St. Jude, moving more to like every 7 to 10 years at times, and moving down from 10 and even going as soon as every 1 to 3 as opposed to 3 to 5. Doing stool tests alone, if they stay negative, is probably fine. But if they turn positive, a single positive stool test really, it's virtually meaningless. It just means you need a colonoscopy. That's all it means. Sigmoidoscopy, Kaiser used to do this flex sig every 5. It only gets as high as about what we call the splenic flexure of the colon, which is kind of stand up. It's kind of right here, which leaves this whole part of the colon unlooked at. So we don't do a lot of flex sigs anymore. They have some nice features. You don't have to do as intensive prep, things like that. But by itself, or even with a fecal occult blood test, really the gold standard is colonoscopy. That's where we're going to end up, regardless of what other tests we do in between to try to, if you don't want a colonoscopy, but if you just want the gold standard test, colonoscopy is the way to go. Okay. Breast cancer screening. So I put this chart in here just to show that, like, for instance, for cervical cancer, this is why we stop pap smears at age 65 in women who are at low to average risk, meaning you don't have any new sexual partners after the age of 65, or you're not sexually active at all. That would make you really low risk. At that point, we see the amount of cervical cancer that shows up after age 8, sorry, the numbers are small, but age 85 or 75 to 84, much smaller than if we slide over here to like breast cancer. You see, almost 20% of cases of breast cancer are diagnosed after age 75. So this is why, looking at the shapes of these curves, it really matters about when we make a decision to stop screening for breast cancer. Gold standard for breast cancer screening remains mammography. Sometimes we'll add in adjunctive things like ultrasounds or MRI or special 3D mammo, things like that. To this date and age, the mammography is the best place to start for most women. So age 75, the USPSTF, which is the United States Preventive Services Task Force, this is sort of a group that comes up with consensus guidelines around screening. They tend to be very conservative, meaning they opt for stopping screening at an earlier or less aggressive time than other maybe society-specific guidelines like radiologists or breast oncologists. My approach is going to be the geriatric approach, was I'm going to sit down with my patient and we're going to look at everything. We're going to look at other, do you have stage 4 heart failure and you can barely get out of bed without being short of breath? Do you have cirrhosis of the liver? Do you have advanced dementia where we think your life expectancy is not maybe more than, a few years? The reason this is important is that on average, it takes about 10 years from the time the test is done to realize the benefit of it. Meaning if you get a mammogram at age 75 in a population, in order to actually, for that population to experience that benefit of mammogram, it's going to take about 10 years. So if someone's life expectancy is, we're guesstimating less than 10 years, which is hard to do, admitted, that's at least the conversation about maybe we don't keep doing mammograms, especially if you've had a bunch of normal ones. If you've had a bunch of abnormal ones and a bunch of biopsies, totally different conversation. That's why these conversations really have to be individualized, and why, owning my bias, I'm not a big fan of hard and fast age cutoffs. It's just there's way too many variables to come up with a hard and fast age cutoff. Some of you may have seen this in the news recently. Certainly caused a kerfluffle in medical social media on Twitter and LinkedIn and all those things. This is coming from the Lown Institute. Lown Institute is a group in the Northeast in Boston who generally the goal is very good. They're trying to make sure that people get the appropriate care, not more, not less. But the title of the article is fairly provocative. Nearly half of older adults get overscreened. Overscreening essentially means screening when it's probably not going to help the patient. So they cite examples of like patients who are living at a higher level of care, like a nursing home, who have advanced dementia, have a hard time making medical decisions for themselves or might not be able to, who are getting things like mammograms and pap smears and colonoscopies. In general, that's probably not appropriate, but it doesn't mean that every 85-year-old who gets a mammogram was overscreened. I think that's where some of us who do work in geriatrics or have a more geriatric outlook pushed back on this a little bit, saying you can't make blanket statements like that. So this is just for you to know when you see your provider, just to bring up if you have questions. And really, this should be a decision reached by you and your provider. I don't think this should be one of those things where your doctor just says, we're done doing this because blah, blah, blah. You have the right to ask questions and say, okay, why? Like, what are the risks and benefits to me of stopping this screening or this test? Prostate cancer in men, obviously. Right now, it's just a PSA every year. We don't do the digital exam as screening anymore. Obviously, I tell my patients, if you're having trouble with like urinating or having a bowel movement or you're having pain, absolutely, I need to do a rectal exam. But if it's just for screening, it's just the PSA. I explain it to my guys. If this is your prostate, this is my finger, I can feel this part. I cannot feel any of this over here. That's about 85% of the prostate I can't feel. By itself, it's certainly not an acceptable test. Even with the PSA, it doesn't add much. So I don't do routine rectal exams. Doctors are different. Some may still do it. That's just how I do it. After age 75, very dependent. And this gets to another big problem in screening, what we talk about lead and length time bias. Prostate cancer, and we know this from autopsy studies where we do pathology on patients having autopsies and looking at their prostate. I mean, estimates as high as 80% of men over the age of 75 or 80 have some prostate cancer when they die, and a lot of them never knew about it, never would have known about it. And that probably goes to the point that at any given time in your body, there are some cancer cells that your immune system is just dealing with and getting rid of. And this is a chronic flux between abnormal cells in your immune system. So prostate cancer is very, very common. So when we screen for it, we're going to find a lot of it. The problem is to date, once we get past age 75, there are really no data that it confers any survival benefit. Now, survival, we've seen this a lot with coronavirus. It's not the end all be all as a summary marker. It's a very gross or very sort of imprecise marker, because there's a lot of stuff in between life and death that matters, like your quality of life. So if you're surviving with metastatic prostate cancer, but you're having to go for, weekly injections of a androgen deprivation drug that makes you feel tired and crummy and no libido, and you have back pain because you have metastatic disease in your spine, obviously that's not great. So again, this is an individualized decision, but I will come down more on the side of saying, hey, you've had normal PSAs for your whole life. You're 85 or you're 80 or you're 75 in this case. In that case, probably 75, I would say we don't need to do this anymore. And that's probably appropriate. Bone density screening, I only have a few minutes left. This is really important because hip fractures are bad. Fractures in general are bad, but hip fractures, because they wipe out your ADLs. You can't transfer, you can't walk, you can't do things for yourself. Even if you get surgery, it's a long recovery, particularly if you have a lot of other medical issues. So we want to prevent fractures. We don't want to wait for the orthopod to get there and, you know, do his or her thing. What they do is great, but we'd like to prevent that. It's all risk factor dependent when to start. Generally 65 for women, 70 for men. But say if I have someone who's a heavy smoker or heavy drinker or both, I'm going to start earlier potentially. If someone's already had a long bone fracture, like when they were 30, they fell and broke their femur or their humerus, I'm going to start screening them then, because by definition, they have some degree of bone mineral disease. If you have an autoimmune disease or you have COPD and you're on a lot of prednisone or steroids in your life, I'm going to start screening you earlier. All these things get dumped into something called a FRAX score, which is really what we care about. The T-score, the scores you get from the DEXA scan are important, but the FRAX score is really what we make decisions by. And typically when the risk of a major fracture, meaning like hip, femur, a major long bone or like a vertebral fracture gets above 10%, even if your T-score isn't necessarily all that bad, which is kind of the summary marker from the x-ray, we're going to recommend treatment. We like to start with things like bisphosphonates, which are like Fosamax or zoledronic acid, what I like to use because it's a once-a-year infusion. And we know that these things actually prevent fractures. Other important things here, when we talk about vitamins, vitamin D, never a bad idea to supplement with a little vitamin D, 1,000 units a day, totally fine. Calcium, it really depends. This goes back to nutrition. If you can eat dairy, like cheese, milk, things like that, yogurt, turns out cheese and milk more than yogurt, you probably don't need to take extra calcium. But if you're a vegan or you don't like dairy, you're lactose intolerant, and you're not getting a lot of animal protein, it's probably a good idea to add in about 1,200 milligrams of elemental calcium a day. So a lot of times you can buy these things combined, calcium and vitamin D. That's totally fine. There was some data that came out a few years ago saying maybe too much calcium is a bad thing, leads to more heart attacks. I think there may be something there, but we don't know for sure yet. That's why I say vitamin D definitely, calcium, depends on your diet. If you really don't eat any animal products, then probably worth taking some calcium, but otherwise I think you can get by with just vitamin D. Last couple minutes, loneliness, depression, and cognitive function. So loneliness has been another big topic in geriatric research for the past 10, 15 years. One of my good friends at UCSF, Carla Parasanotto, kind of got this conversation going because she was able to show in a study that loneliness, when you control for a lot of other things like, you know, income and health status and all that, loneliness still retains some degree of relationship with increased mortality, and is independently associated with things like depression and cognitive function as well. This is one of many articles looking at this. Loneliness is a complex thing. It's not just being socially isolated or living alone. There are people who live alone who do not report being lonely. And there are people who live in, you know, with family or with in a congregate setting, like a nursing home or an assisted living, who feel very lonely. And really loneliness is defined by how the person feels. Do you feel lonely? And if someone says yes most of the time, or yes, 10 out of 10, that is what we're talking about here. So I put this in here because we should talk about it. And because oftentimes, again, wherever you get your medical care, there's a social worker attached who can at least provide you with resources of ways to sort of work away from loneliness. And either that can be in-person meetings or these days, things on the internet. I got to say, coronavirus is a horrible infection, and its knock-on effects in terms of exacerbating these problems for my older patients has just been horrible. So so it's been really challenging for us who do take care of a lot of older adults to try to work around this when we can't actually have people congregating together. Vaccinations. Vaccine schedules are kind of cut and dry. Tdap every 10 years is a great idea. It's not so much tetanus and diphtheria, the pertussis. Pertussis can cause a very nasty pneumonia and cough in older adults, and the cough can linger for months. So I really encourage to get this every 10 years. Flu shot every year. Yes, it doesn't always work that well, but even a 30% reduction in your chance of getting a nasty flu, I think, is worth it. It cannot cause the flu. There's some of you out there who may disagree with me on that, and we'll just agree to disagree. It doesn't cause the flu. It can't. It can cause a very dramatic serum reaction where your immune system goes kind of overboard maybe and causes fever and malaise and chills and all those things, but it's not the flu. It's an immune reaction to the flu. Both pneumonia shots. When Prevnar came out, it was very confusing about how to sort of stage these. Honestly, I have patients get the Pneumovax, the 23-valent one first, just because as it reports, it covers 23 of the most common. Prevnar adds another 13. You get them both, you're really covered. It doesn't necessarily mean you won't get pneumonia. It means if you do get it, you will hopefully not have to go to the hospital. You may be able to just get by on oral antibiotics at home and not feel too crummy. So it limits the severity of disease or prevents it. It works against the most common cause of bacterial pneumonia in adults, which is Streptococcus pneumoniae. So I highly recommend getting that one. And then the last one we really push is herpes zoster, shingles. There's two out there. The difference is Zostavax was called the live attenuated, meaning they took live zoster virus and took out a little piece of it so it can't replicate. Unfortunately, those types of vaccines can cause really severe side effects in patients who are immune suppressed, so they couldn't get them. So now we have Shingrix, which is not a live attenuated. And so more people can get it. So if you've already gotten Zostavax, we still do recommend Shingrix. It's a 2-shot series. You can get it at your pharmacy. Most insurances do cover it these days. That wasn't the case 3 years ago. If you haven't gotten Zostavax, I would get that one to start with, and then Shingrix. It doesn't really matter, though. You can get them in either order. To finish up here in my last overtime, home safety evaluations. If you live alone, these aren't a bad idea. There's no real great evidence supporting their overall efficacy, but I think that's just because this is hard to study. But I do this for my patient. Essentially, I ask a home health agency, whether it's St. Joe's or when we contract with like North Star, or SG, I ask them to send a physical therapist and probably maybe an occupational therapist to your house. And they just do a walkthrough and they look for safety issues. You know, do you have carpets rather than rugs or hard floors that can be tripped over? Do you have, are there ergonomic things we can do better, like get you a shower bar or a support bar in your bathroom? Or, do you have stairs? Like, can we maybe sort of try to get your insurance to at least pay for part of like durable medical equipment, like a lift or something like that? And oftentimes it's required to get those things. So this is one thing you can ask your doctor about. Once you turn 65, most of you are going to go on to some sort of Medicare plan. These days, we really do recommend Medicare Advantage plans just because they are more affordable. They do restrict somewhat what you can get in terms of, provider networks, and it may take longer to get certain things, but in general, we think they're better. It's certainly more affordable. Part of that is your annual wellness visit, which should include a comprehensive geriatric assessment. I use these as an opportunity, obviously, to check in with my patients, but really to zero in on those functional status items and make sure we're not slipping there. And if we are, that's when I'll order things like physical therapy, either at home or going in, occupational therapy, swallow therapy, or if we're having swallowing problems, making sure we know why. And if we know why, then trying to help you fix those. So try to keep up on those. Most places, we are aggressive about getting people in for those, but it's a good time to check in with your provider and bring up some of these issues. Last thing, but probably the most important thing in my talk, the advanced directive and advanced care planning. It's 2 parts, the advanced directive legally. It's a legal document. First is designation of your healthcare proxy. That's the person, not necessarily your spouse or your kid. It's the person you trust the most, and they should know about it and be okay with the decision. It's the person you trust the most to make healthcare decisions on your behalf if you can't. So if you're in a, it's an extreme example, but if you're in a coma and you can't talk, you got to think about who the person you want there communicating with people like me, you're the physician, and all the specialists on your behalf. Okay, that's 1. 2 is the more detailed part of the advanced directive, where you actually kind of lay out things you would want and wouldn't want as it pertains to your care. So I don't want to be on a breathing machine for years and years, or I value life that much that even if it's artificial, I want to be kept alive as long as possible. This is your chance to get that in paper. And any physician who's worked either in outpatient where I work now or before when I worked in the hospital will tell you these documents are so important and helpful because it takes all the heat off your family members to make really, really hard decisions that no one wants to make because you wrote it down. And it's like you're speaking to us, even though you can't actually speak to us in the moment. Some of you will have this as part of your living will and trust. That's fine. It's a great idea to take out the healthcare advanced directive, make a copy, give it to your provider so we can scan it in that way. If you do get admitted to the hospital, we can't get a hold of your proxy, or your proxy's not sure what to do, we can pull this up and say, okay, here's some guidelines. I included a link in here. I think we're going to share the PowerPoint. This is just the stock California document. It's very government. It's very dry. We use a slightly different one at St. Jude. The point is these are legal documents. So as long as you go through it with your DPOA, fill it out, and then get it signed, you know, it is legal. So notary public to notarize it, then you're done. You got it done. You don't need a lawyer. Some people may choose to have a lawyer help them with this if it's complex or if they want to do the living will part. But for this can be done with just you, the person you trust, and then having someone notarize it. And we try to remove barriers as much as possible. Unfortunately, for all the times we talk about it, people often don't do this. So that's the end of my spiel.
Okay, this is Russ again. And I just want to cover a few things. First, we want to thank Dr. Christopher Vercammen today for presenting. We really appreciate that. Thank you, Doctor. I just want to mention a few other up-and-coming classes. We talked a bit about Medicare today, and we do offer in this class on October 24th, we have a Medicare class. It's the Office of Aging. They're basically an organization that does helps you with selecting a Medicare provider. They'll even do one-on-one help with you on that. And they'll be presenting on October 24th at 9:30 in this same class. I did also want to mention that Dr. Vercammen is also presenting next Wednesday evening at 7 p.m. on hypertension. So he'll be doing another presentation next week on hypertension. And we have, for our TIR Essentials on Saturday morning, next week, we have kind of part 2 of our retirement series. And part 2 will be on estate planning. We have an estate attorney, Jay Fullman, who will be presenting. And then the third lecture that we have as part of this 3-part series is on the last Saturday in September, which is the 26th. And that will be Daniel Blunt, a certified financial planner who also teaches a class here. And she'll be talking about dealing with financial planning in this COVID world that we're dealing with right now.